My name is Robert Thomas. I'm a sleep physician with somewhat varying background trainings before I finally settled into sleep medicine. I've been at this since 1996 and have seen many changes in the sleep world, but an increasing interest in sleep and neurodegeneration. When I entered sleep medicine, when I decided to enter sleep medicine, no one thought it was a good idea. In fact, my original plan was to move into epilepsy, but it turned out to be a good idea. So we shall get going with this. And here goes. Okay, so I do have to acknowledge some conflicts. None of them are exactly directly related to this presentation, but I will point out that I've been involved in developing a wearable device system, which can, of course, be used in any kind of sleep condition, including Parkinson's disease, and is licensed to myocardio by the Beth Israel Deaconess Medical Center. Otherwise, it's grants and those types of things. So, getting right away into the meat of things. You do hear a lot about sleep. And much of it is true. Some, of course, is not, is hype. And the truth is, we really don't know what the function of sleep is, because there isn't one function of sleep. Just about every component of the body requires some performance of some function during the sleep state. You can think of it as the best possible housekeeper for the brain, for the cardiovascular system, for metabolic regulation, inflammation, motor and musculoskeletal rest. So all of these are worthwhile spending a couple of minutes on. So brain housekeeping. We know better the role of sleep when we don't get it. This problem with focus, attention, higher order functions, memory, especially short-term memory, affective regulation means behavioral and emotional regulation. The average sleep-deprived person is not particularly a nice person, as you can imagine. But interestingly, it also turns out that if you're sleep-deprived, we are much less able to respond appropriately and recognize emotional cues. Our social cognitive skills actually drop. There's an enormous amount of literature on the benefits of good sleep to cardiovascular function and automatic functions of the body, the sympathetic and parasympathetic nervous systems, which regulate pretty much all the things which happen in the background, respiration, sleep, blood pressure control, heart rate control, bowel movement, you name it. There's an entire cascade of features involved in this type of autonomic regulation. And sleep has intense, complex, and highly predictable effects on cardiovascular and autonomic function, both in physiology as well as in pathology. Metabolic regulation, there is just a lot in here. But very simply, if you don't sleep enough, you will eat junk food. That's putting it very simply. And your metabolism will be more like a pre-diabetic person. And when it comes to diabetes, by the time a person actually has clinical diabetes, you can't reverse diabetes by sleeping well. But those who have substantial sleep pathology, if they're exposed to that for a long period of time, decades, they have more diabetes. Inflammation is a well-known control system, which is modulated by sleep. And in general, sleep restriction, sleep deprivation changes immune function, both suppressing some functions and enhancing some functions. So it tends to enhance the more desirable functions and tends to suppress some functions which are clearly very important. So as an example, whenever one has an inflammatory situation, like a flu, a common cold, etc., sleep is always impacted. We tend to sleep more when we have this kind of sickness behavior, as it's called. Many of the mechanisms involved in disease control are profoundly affected by sleep loss. Thankfully, at least in humans, it's very hard to go very long without sleep. We just end up falling asleep. So you can't really deprive someone of sleep completely for days and days and days. The vast majority of it will just be falling asleep with their eyes open, literally. Athletes know very well the importance of sleep and rest for recovery after strenuous sporting activities. But that's the extreme component. In general, rest of the musculoskeletal system is intuitive and necessary. These are just some of the effects. There are many more effects of sleep. And there are some interesting new facts about sleep, which will be worthwhile simply knowing, and you'll of course hear more of this. Now, in the past, it was thought that sleep was on-off phenomenon, light switch on, light switch off. It turns out that's not so. The sleep is a very active state, and different parts of the brain sleep somewhat differently, depending on how much it has been used in the previous X number of hours. It is a previous day, as an example. So as an example, if you do a complex motor task with your hand for hours and hours and hours in the day, when you sleep that night, your sleep will be deeper over the part of the brain which was involved in that task. Now, just to be alive, just to be conscious, the brain has to do a lot of work. So all parts of the brain do sleep, and all parts of the brain can be awake. But there is an enormous amount of regionalism in sleep. But because we generally use much of the brain much of the time, most of the brain sleeps most of the time when we are sleeping. That's what I call the use-dependent feature, that when you use a part of the brain substantially more, it will sleep more. The glymphatic system is taking a lot of press these days. It's basically the brain's sewage system. The brain has more than one sewage system, but the glymphatic system is an important sewage system, and I'll have a separate slide on it. But think of it as you had to wash out stuff which accumulates when the brain does its work. And of course, you need to distribute important neurochemicals for brain health. It turns out this kind of flow of brain sewage occurs best during sleep, and best during undisturbed non-REM sleep. So as we'll talk later, sleep has REM and non-REM sleep. REM is rapid eye movement sleep or dream sleep, which makes up about 20–25% of sleep. So we need undisturbed non-REM sleep to have very good washout and clearance of metabolites and wastes from the brain. The brain system is a complex network, highly linked network. You imagine a stadium full of people holding each other's hands. You form a network, you form a mesh, and the individual nerve cells have very large numbers of connections to each other. And activity while sleeping in this mesh flows along just like you're standing on a seafront and you're watching the ocean waves. You have, seems almost perpetual waveforms. And that's more or less how the brain works while awake to some extent, and certainly while sleeping. We have ebb and flow of these synchronized waves which travel along the brain, often from the front to the back of the brain. And it turns out that when we are awake, we are forming new brain connections. Our connections behave almost like worms. You can close your eyes and imagine worms, a lot of worms, lots and lots of worms. That's more or less how these little synaptic protrusions are forming new connections, worms intertwining. And what sleep does, among other things, is to come like a housekeeper with a broom and just whack these worms and connections and stresses them out and kills the weak ones and allows the strong ones to survive and get stronger. So that's called the synaptic homeostasis model of sleep, meaning when we are awake, performing, etc., we are learning constantly, and we are learning a lot of junk too. Sitting here, I'm surrounded by so much of different things which I'm aware of and which I see every day. I have no need to keep relearning that. So right now, while I talk to you, I am relearning things which I don't really need to learn. So across the day, we accumulate a whole lot of new connections which have really very little value ultimately. So we need something to come in and prune the hedges. What happens across the 24-hour? So let's start on one part of this diagram. So let's say it's the morning. We are woken up in the morning, where my cursor is, and we start learning. As we start learning, the connections, the synapses get stronger and stronger and stronger. And there are some ones which are really very strong, some which are not so strong. But now the brain is full of very tight connections. Now, if we keep forming tight connections, ultimately we'll run out of connections. And we'll have a whole bunch of linkages which are really not very useful. So then we fall asleep. And very quickly, sleep starts knocking down these synapses. It starts freeing up. It's like rebooting your computer. And by the morning, we're basically ready. So this happens constantly. So every night, our synapses get rebooted. So it turns out that in a wide array of neurodegenerative disorders, and since today we are talking about Parkinson's, I will sort of focus on Parkinson's, but this is true for Alzheimer's and other neurodegeneration disorders. Sleep both starts breaking down because the synapses start breaking down, and the breakdown of sleep doesn't allow proper maintenance of the synapses. So it becomes a vicious cycle. And I can tell you, right off the bat that the average person with Parkinson's disease, especially as it progresses, almost everything which can go wrong with sleep does go wrong. And I'll point out as we go along the things which can go wrong, but pretty much the cohesion of sleep, the depth of sleep, the duration of sleep, the timing of sleep, breathing during sleep, blood pressure during sleep, body movements during sleep, metabolism during sleep. You think of every dimension of sleep starts slowly breaking down in Parkinson's disease, and some parts, of course, break down even more obviously. So this is an example slide of the sewage system which I was talking about. So these are the arterioles of the brain, tiny arteries taking blood. And this little green stuff here is, while you're awake, the amount of this glymphatic or sewage kind of flow. And this is a sleeping brain, the same basic area. You can see enormous increase in this efflux. There's a lot of interest in trying to see whether this is just there or this is actually a problem. That is abnormal or reduced glymphatic flow, is it part of the pathology of the disease, or does it simply reflect disease? Clearly, there are people on both sides. It's very early, but one can reasonably assume that if you have better sleep, you're going to have better sewage flow out, and perhaps that's a good thing. This is a little elaboration of the worms in your brain. So when you are awake, we have these little worm-like protrusions coming from essentially neurites, the little protrusions of nerve cells. And then when you're sleeping, they all get chopped up and they get pruned, essentially. So it's called synaptic pruning. And this has been conclusively shown very well in animal models. But in humans, the brain waves, when you record brain waves while sleeping especially, the way the brain waves fluctuate, just like waves in the ocean, when it's high tide, when it's low tide, you probably know when a tsunami is going to come, etc. And the way the brain waves fluctuate is highly predictive of what the synapses are doing. And we can conclusively show that the amount of tight connections actually drop as the single night goes on. So there's a lot of resetting every night. A final thing to kind of share is that now we may feel like even someone who sleeps through the night, they think, okay, I slept through the night. But that's not really true. Nobody sleeps through the night. Everybody wakes up at night. We wake up intermittently during sleep. We wake up at the edges of REM, non-REM. We wake up as sleep cycles go on. All of us have numerous brief awakenings. So continuity of sleep is a bit of a myth. Now, this image in front of you is from a mouse. And this is brainwaves depicted as colors. So when you have red color, it means the energy of that wave is strong. And when you have blue, when you have the redder it is, the stronger it is. And on the vertical axis, you have the speed of those waves. So generally, when one is awake, the brain waves are very fast. So here, while the mouse is sleeping, in general, fast brain waves are not very strong. The slow brain waves are stronger. Forget the information down here for the moment. But what you can see is that during a chunk of sleep, there are multiple little chunks strung together. So sleep is naturally very chunky, but the chunks are strung together. Why is it so chunky? Not known, but it clearly is chunky. But what's the importance? During disease, this chunkiness becomes evident. And this is true, you don't need to have neurodegeneration for that. If you have anxiety disorder, if you're in pain, if you had a flu, if you're stressed out, bad boss, you name it, your sleep gets more chunky. You're more aware of awakenings. We are consciously aware of a fraction of the awakenings which we experience. But in neurodegeneration, sleep gets very chunky, can get very chunky. And in the worst case scenario, there is a complete smearing of sleep in small little bits all across the 24-hour without any clear sleep-wake cycle. So this capability of being chunky is innate, it's natural, and disease brings it out. A few words on light. So RPGs are retinal ganglion cells. And these are cells in the back of the eye which get a convergence of information from the photoreceptors, the receptors which actually sense, light, dark, color, etc. Now there's a small number of RPGs, ganglion cells, in the back of the eye, like 1%, which have a substance called melanopsin. This is a very important discovery because this explains how we are able to entrain to light and dark cycles. Later on in this talk, I will be giving you some circadian information, but most living things evolved in this light-dark cycle of the Earth, and we needed a way to keep track and predict when it's going to be light, when it's going to be dark, so elaborate photoreceptive systems, circadian photoreceptive systems came about. And melanopsin is key for the non-photic, the non-visual system. That is the system which is not image forming. Okay? So melanopsin is the non-image forming system. So it'll be the light and dark, various grades of illumination, but not image forming. It's responsible for numerous things, including cognition, mood, alertness. The pupillary reflex, the pupil contracts with light. And this is incredibly important for neurodegeneration because the circadian system is often badly impacted. And one of the ways to improve quality of life and quality of health, including brain health in patients with Parkinson's disease, is circadian manipulation or light treatment. There are a number of grants which are currently active trying to figure out the best way to use light in patients with Parkinson's disease, how it improves their mood and their cognition and sleep-wake cycles and so on. There are formal recommendations for light, dark, and very simplistically, when you're sleeping, it should be pitch dark. In the evening, it should be not more than 10 lux of light. How can you figure out what lux? uh, on iPhone or Android, go to the App Store and look for Lux Meter, Luxmeter, light meter, Lux Meter, and it'll use your phone's camera to tell you how much lux you're at. It's very hard to guess how much lux you're at. But once you turn down the lights, you will realize that once your eyes dark adapt, you can easily see quite well in 10 lux or less. So lots of brightness in the daytime, 2-3 hours before bedtime, 10 lux, and while sleeping, no light. Unfortunately, if we sleep under light, there are really undesirable effects on us. It changes our metabolism, it changes our cardiovascular regulation, it shows signs of stress. We live in a light pollution world right now. So it's really important that you have a clean light-dark cycle, you have a clear evening, a clear morning, and a very clear night where there's virtually no light. How much sleep? Well, 7 hours is the American Academy of Sleep Medicine's recommendation. And clearly, some people sleep less, some people sleep more. I don't sleep 7 hours myself. I'm a 6-hour-ish all my life. I'm a shorter sleeper. My whole family, we tend to sleep short. There are families where people sleep 9-10 hours easily, effortlessly. 7 hours is probably okay. If anyone gets less than 5 consistently, it's probably not normal, and needing more than 10 is probably not normal. There are some true long sleepers who need 9-10 hours and they feel perfectly fine, but that's not common. And there are clearly some folks who sleep 3-4 hours and they feel fine, and there are now some genes which have been discovered which allow them to do so. But most of us aren't quite so lucky. Common disruptors of sleep, and these are very, very common in patients with Parkinson's disease. It's not unique to Parkinson's, but clearly patients with Parkinson's is really very common. And some of this is intuitive, pain, anxiety, depression, stress, sleep apnea, circadian misalignment, drugs. Levodopa reliably can cause insomnia. Medical training, of course, not relevant to Parkinson's, but I use this talk for other reasons too. What is optimal sleep? Sleep duration has been getting the press, but there is a movement towards looking at sleep as something which is much more multidimensional. So on the subjective domain, how alert you feel, how rejuvenated you feel on awakening, and the feeling of continuity of sleep are all important. And there are questionnaires which can actually assess these. Objectively, there's a large number of measurements which are possible. Duration, circadian alignment by, say, measuring the melatonin profile of the person. The melatonin goes up in the night and comes down in the day. Motor system, whether you're kicking, whether you're moving, whether you're yelling during sleep, blood pressure going up, going down, heart rate changes, and various other measurable features from the brain waves, and I'll share some of that with you. These and of course, there's immune function, there's endocrine function. There's so many dimensions of what should fall into place if we are sleeping well, that the idea of using just sleep duration seems so naive. But the American Heart Association has added sleep duration as the 8th factor for cardiovascular health. So the American Heart Association has had the simple 7s for cardiovascular health. Well, now it's called a simple 8, which includes sleep. The others are intuitive, like don't smoke, stuff like that. So what is optimal sleep? American Academy of Sleep Medicine says 7 hours is good. Very important researcher called Dan Bicey has this questionnaire called Are You Sated? Are you sated? Twitter talk. Regularity, satisfaction, timing, duration, efficiency, alertness. There's a sleep health index from the National Sleep Foundation, 12 items. None of these integrate objective measures. And believe me, patients with Parkinson's disease, they do not have optimal sleep. Almost all these dimensions go wrong. How to measure regularity? So the idea of regularity is getting some prominence because there is some data suggesting that independent of everything else, independent of hypertension, cholesterol, age, sex, etc., that sleep irregularity, which means you go to bed and you wake up at different times every day, basically, increases atherosclerosis and increases bad cardiovascular outcomes like heart attack, hypertension, makes for worse metabolism like prediabetes, and impairs mood. There are many ways you can measure regularity. One is just a standard deviation. Day to day, how much do you vary? Okay. Then you have something called interdaily stability. That is, if you're sleeping at 10 o'clock today, how likely is it that you're sleeping at 10 o'clock, 10 p.m. tomorrow? Similarly, just think of all the time points across the average sleep period. How consistently are you sleeping at that time or not can be mathematically quantified. Social jet lag is a mismatch in average mid-sleep, the middle of your sleep timing, workday and free day. So if you go to bed at midnight and get up at 6 on your work days, and then you go to bed at 2 o'clock and wake up at 12 on weekends, now take your midpoint there, that's a pretty severe social jet lag. So social jet lag more than about 2 hours seems to adversely impact at least metabolism and mood, and probably hypertension. And there are other measures which can be computed fairly easily, mathematically anyway, to show this regularity. But often it is very evident visually, okay? So on the top left, the green is actually a very regular individual. They go to bed and they wake up at the same time. And this is using wrist activity monitor. This is from an epidemiological study, just an average population study. In that same study, another individual looks like this red. Just naturally a very variable sleep time. Now it turns out in my sleep clinic, I actually have a circadian clinic. Besides my regular sleep clinic, I have a circadian clinic where I deal with body timing disorders and so on. So the middle snapshot is a 40-year-old person who most of his life doesn't really know his bedtime. This turquoise color is estimated sleep. And you can see how it just flies around the place. This is again using a wrist activity monitor. This is the activity. He gets treated with lithium. We won't talk details of lithium right now. And he stabilizes. So this regularity dimension is seeing increasing importance. This is just a duplicate, sorry. Okay. So now we talk a bit more about what we measure. Now we can measure sleep in so many different ways. Your smartwatch measures movement. It measures pulse rate. It measures respiration through the pulse rate, pulse wave, fluctuations, and can give a reasonable estimate of deeper, lighter, and REM sleep in average healthy persons. Okay, not in disease. In disease, it breaks down completely. So if any of you use a smartwatch, and I'm sure some of you do, and it has sleep tracking, you can believe the trends, but not the absolutes if you have Parkinson's disease. Plus, with Parkinson's, you have a movement disorder, and the movement input into the watch is a very important way in which it decides what is what. So clearly, you don't want to just blindly believe that. However, in my clinic, I do use it to track the effects of my treatment because the trends are clearly more valuable. Then you may go to a sleep lab, and some of you probably have had sleep studies where they paste electrodes on your eye, chin, head, and you have 20 different things pasted all over your body, looking at your oxygen, your movement, your breathing, and so on. That's the other extreme of it. And in between, you have different ways of measuring individual physiologies and then calculating some sleep. And now you can do it without touch. There are no touch devices. There's a system developed by Dina Katabi at MIT it's based on Wi-Fi, and it's stuck on your wall, and it's scanning you. And essentially, it knows whether you're walking, sitting, lying, sleeping, deep sleep, light sleep. It's amazing. The way a big brother can track you is actually quite amazing. Nevertheless, this is the original kind of way of thinking about sleep, where you have across the night, you have deeper sleep earlier in the night. And this black is REM sleep or dream sleep, and more dream sleep across the night. And sleep goes in cycles. So one REM and non-REM is a cycle, another one is a cycle. As the night goes on, sleep gets lighter, but REM gets stronger. So this is it's called a hypnogram, a classic hypnogram. And this is an example of, from my sleep lab. These are people with complaints. So these are patients often with sleep apnea, or they have restless legs, or similar types of problems. But gives you the basic idea that even in disease, for the most part, the fundamental architecture of sleep is reasonably well preserved. The blue here is deeper sleep, the green is light sleep, the pink and black is REM sleep. So you can see the cycles. Now, on your bottom, you have a much more fragmented sleep, where there is a lot of limb movements. These blue and red items at the bottom here are a person kicking the legs while sleeping, and you can see these little yellow things are transitions to light sleep. So this person is wobbling between average sleep and light sleep, doesn't have that blue tag, doesn't have much deep sleep, but still has the basic architecture. The gray zones are full wakefulness. So here there is more wakefulness during sleep. There is more transitions during sleep. And this is often typically what happens in the early stages of Parkinson's, that sleep gets more fragile. The basic architecture is maintained, but there's more transitions. There's more vulnerability of sleep. And now we are getting out of hand. You have on the top left, you have someone with a lot of wake chunks. They're spending big chunks of time wake at night. They may be napping in the daytime. And the lower right, you have a person who looks like a rat. I mean, sleep is completely broken down. You don't see the pink and red. You don't see much of the blue. You see mostly grays. And this would be how a person with Parkinson's could get to, doesn't have to get to, but could get to. And a lot of this we can help. So it's not like, it's a one-way ticket to nowhere. We can actually help. But it gives you a sense of how you can close your eyes and conceptualize how good, nice, cyclical, deep light kind of sequencing across the night starts slowly breaking down, ultimately where you have complete loss of this rhythm. The deeper, lighter REM rhythm is just completely lost. And along with that, of course, all the functions of sleep also get degraded. More examples, just to give you a sense of, we see all these various patterns. In the lower one, you have no deep sleep. You have one big cycle and another small cycle. So these kinds of distortions, when we look at sleep and we do sleep reports, we try to match the description of the patient with what we see on sleep studies. Now, we clearly have to give some slack for being in a strange environment. However, with wearable devices, including home wearable brainwave monitors and so on, we can do these kinds of recording, much of these in the home, and remove the effect of being in a sleep lab. All right, so now I'd like to go a little bit deeper and try to use analogies as much as I can to try to explain how sleep is impacted in neurodegeneration and Parkinson's and medication effects, stress effects, and so on. So a spectrogram is basically a breakdown of the components of a primary signal. So all of you, I'm sure most of you have heard The Dark Side of the Moon. In fact, I was listening to it yesterday, Pink Floyd's album. This is not obviously that album cover. If I showed you that, they'll probably sue me for infringement. Anyway, this is white light broken down into its components. So similarly, almost everything in the body which occurs with a rhythm of some kind it gives out a signal which can then be broken down into components. So the ECG can be broken down into components. The EEG, brain waves, can be broken down into components. Movement can be broken down into components. Say when you're walking, some parts of you are moving differently than others. When you're dancing, of course, that is more obvious. And brain waves can be broken down into what's called the EEG spectrogram. So don't get frightened by this image, but this is more or less how we break things down and show it. Now, let's start with the lower right. This is the hypnogram. You will remember you have a sleep cycle, the second sleep cycle, third sleep cycle, fourth sleep cycle. You have periods of deeper sleep, periods of lighter sleep. There are some transitions. This person's in the sleep lab with stuff on their head. Of course, they're going to have some awakenings. But you can see there is more deeper sleep, blue, in the first half of the night and more pink and red REM sleep in the second half of the night. Okay. Now, this is that same person. So how you read it is that on the vertical axis are the slowness. So right here at the bottom is the slowest of slow waves. And when we are sleeping, the brain waves slow down. And right on top here is the faster waveforms. Okay. And the color is par. The redder you are, stronger it is. And become blue, you're blue, it's very light. So across the night, you can see how there is this ebb and flow of the depth of sleep. You have these slow waves build up, they drop briefly, they build up, they drop briefly. You see these little chunky little things? Remember the mouse slide I showed you with fractionated sleep, with chunky sleep? You're seeing a little version of that here with this kind of chunkiness. But overall, across the night, you have this ebb and flow of slow brain activity. Slow brain activity means large parts of the brain are slowly synchronized and moving up and down electrically together, like it's doing the job. It's like fluffing your blankets, fluffing your brain blankets. Think of it that way. This band here is spindles. Now, sleep spindles look like spindles. And think of it as cell phone carrier waves. The 5G network of your brain is the sleep spindles. It's information carrier waves. And they have a very distinct band. It's about 12 to 14 times a second, basically. It's a very distinct kind of band. But the majority of the information content is in the slow part, and much less. So the red is high energy, right? So much of it is in the slower part. So now I'll show you some abnormal examples, and that is the kind of features which unfortunately occurs with neurodegeneration in general, but Parkinson's being a very good example. Now the samples I'm going to show you, only one of them is Parkinson's. The rest are just examples. So this is an example of a person where if you just think back, okay, that's like a well-trimmed hedge, a nice garden, a good English garden. Now this is a garden not very well kept. I don't need to go through the features to recognize, for you to recognize that this is distinctly different from this. And now here, this is also distinctly not good. You can see there are a lot of transitions from the deepest sleep to awakening, deepest to awakening. This person is a sleepwalker, walks during sleep, and actually has a lot of these awakenings and does stuff, goes to the kitchen, goes out of his house and so on. So it doesn't mean that he does this every time he wakes up, but these abrupt awakenings are not normal, and it occurs on and on through the night. Even when the deepest of sleep, he has these abrupt awakenings. So this is an example of what's called a parasomnia, or a behavioral event during sleep. A person may wake up, feeling startled and like there's a shadow in what we call a night terror, or they can get up and walk and do stuff. Here you see that there is clearly a lot of this slow activity, which is good, but there's also a lot of fast activity at the same time. So this band on top here is a much faster activity. So this is called the alpha band. And alpha normally is present when you sit quietly with your eyes closed and kind of zen out. It's the brain's idling rhythm, more or less. When we fall asleep, the alpha goes away. And when you're awake, you open your eyes, the alpha goes away immediately. Normally, when you're sleeping, the alpha should be hanging around. But here, the alpha is hanging around big time. So what that means is that the brain is now trying to create two different kinds of music at the same time with the same instruments. Guess what will happen? Won't do its function well. So when you have smearing and smudging of the different frequencies of the brain, the different oscillations of the brain during sleep, it loses its functionality, at least its functionality is reduced. Now, this is a person with Parkinson's disease. You can see that there is a certain amount of slow activity throughout the night, but the ebb and flow is not there. If I go send you back to the healthy, look at that. There's this ebb and flow, deeper, lighter, REM, non-REM, deeper, lighter. This is flattened out. And it's not diagnostic, but it's very typical of neurodegeneration. The brain waves permanently slow down. It's slow during sleep. It's slow during wakefulness. So the brisk, crisp oscillations of the brain, the tight music of wakefulness in health starts getting contaminated by much slower activity. And that slowness also correlates with attention, cognitive function, and so on. So if any of you have had a regular EEG because your neurologist was worried about cognition, they're looking for slowing, excessive slowing while you're awake. Okay. Now there's another dimension of sleep called the stability domain. Just like you can be tall and thin, you can be short and thin, you can be broad and short, you can be tall and broad, right? So you can have deep sleep, light sleep, but you can have stable sleep, unstable sleep. You can be light and stable, you can be deep and unstable, and the reverse. And in general, healthy sleep has a lot of stability. And neurodegeneration reliably reduces stability markedly. Often before the depth is changed, the stability changes. So in front of you is a snapshot from a sleep study. 5 minutes, there's brain waves there, there's breathing down here. All I want you to take is a bit of a 30,000-foot view and see how you have these repeated things happening every 40 seconds or so. And the same person a few minutes later switches into suddenly entirely different behavior. Completely different behavior. Within a minute, the person switched from this one form of music like playing heavy metal and now is playing Bach. This kind of flip back and forth is natural. It occurs in everybody. It occurs, well, we have shown it in mice and dogs and cats, humans, of course. So presumably it is fairly tightly conserved, that this stability domain is tightly conserved, and everything which makes sleep better tends to enhance stability, and everything which disrupts sleep tends to enhance instability. And patients with Parkinson's have very unstable sleep. Even if everything else is equal, they really have unstable sleep. And this I can say with substantial confidence because I've been seeing patients with Parkinson's, enriched clinic with Parkinson's for nearly 20 years now, and we have hundreds of sleep studies we have seen, and this instability domain is really very common. How would you characterize instability? So this is a technology which I was involved in developing. It has taken many forms, but now it's a form of a little ring. And it measures from the arterial pulsations, the artery pulsations in the finger. It measures oxygen and it measures heart rate changes and respiration changes, and then generates an image. It's called sleep image. And this is a normal image. The upper mountain range is stable sleep. The lower mountain range is unstable sleep. So on the right, you have a person with predominantly unstable sleep. There's very little in the top mountain range. Much of it is in the bottom mountain range. This person has sleep apnea, but you don't have to worry about that. Just to give you a sense of the way one can track and demonstrate the stability of sleep. The bottom panel is the person who has variable sleep timings and sleep quality night to night to night after COVID. So as part of long COVID, the person was a perfectly normal sleeper before developing COVID and now has this unfortunate pattern. You can see every night is a little bit different. So there's instability. You look at the top mountain range, every night is a little bit different. So there's instability of the quality of sleep. So the stability domain can be actually tracked. Most sedative drugs, any effective sedative drug will improve stability. Treating sleep apnea improves stability. Proper use of levodopa to help the Parkinsonian motor abnormality helps enable stability. Just as a quick comment, when you're actually sleeping, you have no Parkinson's. But each time you have the smallest awakening, the motor system abnormality will come through. So while actually sleeping, there's no rigidity, there's no tremor in Parkinson's, there's none of those. Circadian rhythms. Okay, so brain, optic nerves, light from the eye, small part of the brain called the hypothalamus, right at the bottom part of the brain, has this little nubbin, which essentially is called the suprachiasmatic nucleus, which is a master regulator of all body rhythms. Every single rhythm in every single organ system, and every single organ system has very complex rhythm. This little fellow modulates all of it. It's worthwhile spending a couple of minutes on this idea of interaction between the sleep system, which I have been largely discussing, and the circadian system. Essentially, sleep is a bit like a credit card. If you're up for a while, you build up sleep drive. You're putting payments on the card. And until you pay it off, that debt does not go away. So across the day, you build up a sleep debt. And when we sleep, we pay it off and we kind of reset. But why do we sleep when we sleep? It's because the circadian drive increases across the day, helps us stay awake, and at night automatically turns down, shuts off, and restarts. So this is our biological night. When the circadian system drops its energy and the sleep system is paying off its sleep debt, we are fairly impaired. Even the average healthy person, if you ask them to do a task, a mental task, in the middle of the biological night, their performance will be impaired. So the circadian and sleep interaction is what determines when we sleep. It also determines to some extent how well we sleep. So in Parkinson's, a very important feature is flattening of the circadian drive. So this flattens out so that the difference between day and night starts eroding. So it's very common for patients with Parkinson's disease to start being sleepy in the daytime, which can be part of Parkinson's itself. And their sleep-wake differentiation starts getting dulled. So there's more sleep in the daytime, there's no wake at night. And this is why using light, strong light in the morning when you wake up, strong light throughout the day, and clear darkness while sleeping makes these rhythms stronger and makes the sleep-wake differentiation tighter. And that gives rise to better sharpness, mood, cognition, and so on. We can measure the circadian system's output by activity monitoring in mice, monkeys, humans. These are so-called double plots. Just step back and think of it as if your rhythm is more than 24 hours, you will go forwards. And if your rhythm is less than 24 hours, you'll go backwards. So it turns out that a pigtail monkey and a mouse is slightly less, is 23 hours and some minutes. So it goes backwards. While humans, we go forward. For this to be expressed, we have to be in complete darkness. We have to have no light dark cues. We have to be basically zenning out and letting our body's rhythm demonstrate itself. Now, there are complicated experimental protocols to do so. And all of them show that the human clock is about 24 hours and 12 minutes or so, slightly longer than 24 hours. And every day we get reset slightly by light and dark. This is what happens when you kill the suprachiasmatic nucleus, the master regulator. And the suprachiasmatic nucleus is unfortunately impacted by Alzheimer's and by Parkinson's. If you kill it, and this is a monkey, you kill it, you become completely irregular. Unfortunately, that does happen in neurodegeneration. Entrainment. You have a clear light-dark cycle. You're nicely synchronized. Now here you are in complete darkness and you move out. You get back to light-dark cycle, you synchronize. That's thankfully how we respond and how we survive jet lag. If jet lag was not reversible, we would never travel, we'll die. But the circadian system is very adaptive. It's able to somehow find its way around the globe, give it enough time, all body rhythms resynchronize. Of course, there are a whole range of circadian rhythm disorders. I run such a clinic where we see patients with very unusual timings, and the timing is just the superficial part. The whole body rhythms are actually out of sync. This is activity monitoring with a wrist bone. It's called Active Watch. This is a healthy person, and wakes up by about 7, 8 in the morning. This is activity across the day, starts settling in by the evening, and by about 11 o'clock is sleeping, and at night is nice and quiet. So this is a normal actogram, activitygram. Fitbit will give you something like this, and all the wearables. They don't give quite this kind of view, but it gives similar information. Now, this is a person with Parkinson's disease, with irregular sleep-wake cycle disorder, meaning you have 3 or more chunks of sleep in any 24-hour. You can see there's a loss of the day-night difference. This is a patient with Parkinson's disease who has severe insomnia as a dominant complaint. So we basically did activity monitoring, and you can see that there isn't a clear zone of quiet. There's the black tags are movements, and the movements everywhere. Part of it is, of course, Parkinson's itself, but there's movements everywhere. The yellow is light. The light is on quite irregularly too. So this person is kind of awake, the light is on, then falls asleep, or rests and the lights are off, and then gets up and does stuff and the lights are on again. So when you do that, you're effectively like you're traveling to different countries, different time zones. And this kind of breakdown of the sleep-wake cycle, unfortunately, is common in neurodegeneration in general. It can be seen after traumatic brain injury, can be seen in Alzheimer's, brain tumors, extreme age, sometimes in depression, brain tumor. Just think of, you won't see the stroke. The average stroke patient does not do this kind of stuff. Strokes generally cause sleep apnea, more commonly. It doesn't break down brain unless they're extensive strokes. It doesn't break down brains like neurodegeneration does. Okay, I will stop there, and I'm happy to take any questions. I didn't talk about sleep apnea because, everybody with Parkinson's has some degree of sleep apnea, and if it's mild, we ignore it. If it's substantial, we treat it. We treat it with, mask, air pressure, that type of thing. I didn't talk about REM behavior disorder, though I'll say a few words about it because that needs really a whole talk almost on its own. But normally in REM sleep, the muscles are paralyzed. And in REM behavior disorder, the muscles are not paralyzed, and the dream the dream content is very aggressive. So the combination of the two results in motor behaviors during sleep, which are usually very, fairly aggressive. A person can jump out of bed and imagine they are running, and they run into the wall and so on, and can cause injury. REM behavior disorder is quite common in Parkinson's. Mild REM behavior disorder, probably a third to fourth, and ultimately probably 50–60%. Interestingly, REM behavior disorder can precede Parkinson's, and some of you perhaps had REM behavior disorder before you started having Parkinson's. I'm happy, of course, to answer any questions about sleep apnea, REM behavior, and all that. But I thought today I should focus on trying to share with you something about sleep itself and how it could be measured and the kinds of things which allow you to think a bit with somewhat more sophistication about your sleep, and then try to make it better, along with your neurologist, or if you're seeing a sleep physician. Hopefully you can have a somewhat more sophisticated conversation and you understand why certain recommendations may be given and so on. So I'm now happy to take all kinds of questions.
Great. Feel free to type questions in the Q&A. We've got a few in there so far. One is, how would I know if the chronic lack of sleep over months and years is affecting my heart?
It's much easier when it's sleep apnea, where you can show that the heart muscles get thicker. Because when you have apnea, your breathing is stopping and starting during sleep. Blood pressure fluctuates. So your heart kind of gets a workout of sorts. So the heart muscles get a little thicker, a little stiffer. Now, with leaving aside sleep apnea, if you have poor sleep for a long period of time, one feature which can be seen is that your heart rate variation, there is normally what's called heart rate variability, which is determined by sympathetic parasympathetic balance, will start becoming more sympathetic than parasympathetic. And you can show that while awake, you can show that while sleeping. So patients with insomnia, as an example, just average, not Parkinson, average person with insomnia, their heart rate variability profile is sympathetic dominant. A person with post-traumatic stress disorder will be sympathetic dominant. A person practicing meditation regularly will be parasympathetic dominant. A young, healthy adult who works out, is happy with life, good job, good family, utopia, will be parasympathetic dominant. And it's fairly dynamic. So on a given day, you may be more parasympathetic dominant, and the next day with some bad news, you may be more sympathetic dominant. And you can see these changes while awake or while asleep. It's usually clearer during sleep because sleep offers a certain quietness to collect good quality data. So objectively, that perhaps is the best way we have now. And so, long-term effect. Over the short term, disrupted sleep will cause, obviously, things like blood pressure at night normally goes down. It's called blood pressure dipping. Any cause of sleep disruption will disrupt that. And your blood pressure will be higher during sleep than it should be. And sometimes it is higher while sleeping, while wakefulness. This is called reverse dipping. It goes the other way. And that's really bad for the heart and so on. So to look at the impact of poor sleep over the long term on the body, it's hard to tease it out from other conditions, but it's possible.
Great. And then somebody asked to clarify, did you say that levodopa causes insomnia?
Can cause. It can reduce insomnia by targeting Parkinson's, and by itself, it can cause insomnia. It can cause hallucinations during sleep and around sleep onset also. In fact, levodopa psychosis used to be a common enough problem in my younger days of dealing with Parkinson's patients before I came to the US, where we had basically levodopa. We did not have many of the drugs you have today, so we had to push levodopa to the highest tolerable dose, and insomnia, hallucinations, and such were unfortunately common. So if it's used carefully, it'll be fine. But just be aware that there's a little trade-off. If you wake up a lot at night and you have Parkinsonian features and you need to use levodopa at bedtime, careful dose titration will generally get you to a reasonable trade-off.
And then in a sleep study, how do they determine restless legs compared to dyskinesias?
So restless legs equivalent while sleeping is called periodic limb movements. It has a very characteristic cadence. if you can see my hand, imagine this is the foot. It looks usually a bit like, well, this is your foot. It goes up, down. That's the kind of speed it does. And it occurs about every 40 or so seconds. And the whole limb can move, or sometimes just the foot moves. And usually there is a little bit of brief awakening, or the heart rate goes up a little bit. So those are called periodic limb movements. People with restless legs, they can have that while they're awake. When they're awake and say watching television, they can have little twitches, jumpiness, and little kind of leg movements while awake also. It's fairly distinctive, and tremors and other movements just don't cause this, very rhythmic. There are very strict criteria. You got to have 4 or more movements with a certain duration, a certain repeat interval. So it's quite hard to mistake it for anything else.
Great. And then regarding sleeping in a bright room, is it adequate to wear a mask to block excessive light, or does the entire room need to be darkened?
If you use welder's goggles, I suppose is okay, but short of that, it's much better to just turn the lights down. It's hard to, well, I'm sure a really good mask is probably fine. Yeah, it needs to be a really, really good mask, and it has to stay on. Even a light coming through here is enough. We are extremely sensitive to light in our biological night. The biological night physiology is entirely different. Almost every measurable thing is different. When the melatonin goes up, normally in the daytime, melatonin is at a very low level. In the evening, it starts rising. They're telling us that this is evening, night is coming, biologically speaking. And then it peaks in the middle of the biological night. And that time we are very sensitive to light. So in fact, in my bedroom, we have, there's no light. Even the bedside clock, we kind of removed that. Those digital things is too much light. We put an old-fashioned wind. That's what we have in our bedroom. Our bedroom is totally dark when we sleep.
And do you advise going to sleep listening to the radio?
So children can have a disorder called sleep onset association disorder. It's one of the causes for insomnia in kids, especially toddlers and such, where they develop a need to have a certain environment before they can fall asleep. Sometimes it's a parent's arm, sometimes it's rocking, sometimes it's a certain sound, etc. And in adults, an association disorder is less kind of considered because we kind of control our environment while the child may not control the environment. If a person needs that to fall asleep, but then without it, they have trouble falling asleep, it becomes then the childhood equivalent of an association disorder. But by itself, anything which enables a person to fall asleep is okay. I no longer, for many years now, I've stopped telling patients to not watch a movie in bed or use their cell phone in bed. They're going to do it anyway. So that is their association. And it's not a worthwhile battle, but what is worthwhile is the light exposure during that time. So as long as they're aware that they really have to absolutely minimize the light, turn on the black background and lower the intensity, all of that, and use the lux meter, the light meter, to be less than 10 lux of light. That's okay. And I certainly ask them to not have cognitively engaging information at that time. So if you listen to a podcast, let's say you're a heavily politically active person and you're listening to a politically driven podcast at bedtime or in bed, that's probably a bad idea. But listen to a podcast about the weather, maybe it's okay. War, probably not okay. About English literature, probably okay. So you want something which can lazily, cognitively dance with you, but not something which you are, deeply into, because that will cause cognitive arousal and that will make it harder for you to fall asleep. Now, that being said, the world has a lot of really good sleepers. Unfortunately, myself inclusive. There's almost nothing which can disturb my sleep. I can work on my laptop right until bedtime, close it, get into bed, and I'm gone. My wife, she needs almost a 2-hour wind down. So you need to understand, what kind of works for you and what not. But I don't lecture people about what they do at bedtime. I do lecture them about light, definitely, but much less so about what to do and what not to do. Keeping the TV running all night long, that's not a good idea for 2 reasons. First of all, there may be some light, okay. But more importantly, we habituate to sound during sleep, but a constant sound. When sound fluctuates, it causes arousals. It's like the brain is sleeping, but it's kind of keeping track. So when you watch, well, if the TV is on, guess what? The sound will fluctuate. There's ads, there's stuff going on. So the fluctuating sounds, you don't habituate to. When there's a rapid change in sound, you will have an awakening. So I do recommend about not letting the TV run during sleep.
And then can you speak on chronic excessive sleep in Parkinson's between 10 and 14 hours per day?
An unfortunate outcome in a subset of patients, which is called technically hypersomnia. Hypersomnia means sleeping excessively. Well, technically, there's a version of hypersomnia where you don't sleep excessively. But for practical purposes, when we use the word hypersomnia, we really mean this person is sleeping too long. If they don't get that long sleep, and they are very impaired, even after they get that long sleep, they're still impaired. If they've woken up in the middle of that long sleep or the end of that long sleep, they still feel very foggy, brain fog, sleep inertia, where you really feel like you're on 0 gear when you wake up. Okay, so all that's part of it. It's not an inevitable outcome of Parkinson's. So I'm just trying to think of if I go back to say my last 100 patients with Parkinson's disease who have managed sleep, maybe 10 are truly hypersomnic. Most of the time, the sleepiness is just like they're sleeping in the daytime. They're not just sleeping in the daytime. So they're sleepy. So, when they settle down, they kind of nod off. But sleeping means you're out. That's hypersomnia. It's really, really hard to treat. But there is now a FDA-approved medication called Xywav. Leaving aside the name of it, it's a very sedative medication. It's a medical grade gamma hydroxybutyrate. You take it at bedtime and you take a second dose in the middle of the night. It causes a deep sleep-like state. We call it sleep-like state because it makes it, essentially, it is anesthesia. It anesthetizes you during sleep. And it seems to shrink the sleep need. Now, it's not being studied seriously in Parkinson's disease. There was a trial many years ago, but I haven't seen anything more come out of it. I guess fear of using something so powerful in a person who is so fragile. But those who don't have Parkinson's, I have numerous patients with hypersomnia who use this medication. Stimulants, standard stimulants like methylphenidate, amphetamines, or modafinil, so-called Provigil. These help some in hypersomnia, but they don't help very much because, stimulants work best, caffeine inclusive, works best in the biological day. So those who have hypersomnia, someone sleeping 14 hours, 15 hours, their biological night probably is prolonged. And in the biological night, stimulants don't work very well. So a Parkinson's patient with hypersomnia is probably one of the hardest things to help. I would be personally open to trying, oxybate medication, but with great caution. And of course, it's a very expensive medication, more than $100,000 a year. So you can imagine there is, very precise testing needed to qualify for it and so on. I'm not anxious to have my Parkinson's patients line up for this medication for sure.
And then a number of questions on a few supplements, including melatonin, marijuana, lorazepam, and Lexapro.
Okay. I can start with cannabinoids in general. Um, Cannabinoids are very powerful stuff. They impact behavior, memory, pain control, cognition, motivation, all of that. There are two ways to look at use of cannabinol, marijuana, and other project and other, cannabidiol or THC, etc. in Parkinson's. In either way you look at it, you are taking a risk. Trying it under supervision is probably okay. If it clearly is of benefit, and whatever the benefit may be, whether it is for sleep or mood or pain, a substantial minority of Parkinson's patients have pain, and cannabinoid can help. So don't do it on your own. You need to really work with a neurologist. Hopefully a neurologist will be willing to work with you. But you got to treat it like a drug, not a supplement. You can do damage. It can cause psychosis. It can cause depression, change in behaviors, and levodopa can cause psychosis. Parkinson's can cause psychosis. The dopamine agonists in general can cause psychosis. You've got to be careful. So if you have decided that you're going to use a PrEP, then you want to standardize it as much as possible. Same manufacturer, same dose, same timings. And if you make a change, it should be like you're dealing with a change in drug dose. So with all those precautions, I don't have any objection to my patients, including those who don't have Parkinson's and those who have insomnia. It is a bit of a user beware, buyer beware, but I really want them to consider it not as a supplement, but as a drug to be used with care. And if it clearly is beneficial, that's fine, but be aware that adverse events are around the corner. They may never really come around the corner fully, but they're there. Melatonin. Melatonin has at least 3 different effects. So one is a hypnotic effect. That is, it makes you sleepy. Unfortunately, standard dose melatonin makes only a minority of people really sleepy. These are the melatonin sensitive people. They take a tiny bit of melatonin and they feel groggy. So if you're one of those, then melatonin can be used for sleep. Now, melatonin will work best when it's given close to your biological night. If you can't fall asleep until 2 in the morning and you take melatonin at 10 at night, it's not going to work. That is when you use it as a hypnotic. Okay. The dose, I would say not more than 5 milligrams. I usually suggest, I use melatonin for my patients quite a bit, but like a drug, you can try 1 milligram, 3 milligram, 5 milligram. If 5 doesn't help you at all, it's probably not worthwhile going further, because then it can hang over and cause daytime sedation the next day. There's a chronobiotic use, meaning body timing, a circadian use of melatonin, where you take 0.3 to 0.5 milligrams about 4 hours before your target bedtime to amplify the biological evening. So I normally tell my patients who have an average sleep schedule, turn the lights down at 8 p.m. and take 0.3 milligrams melatonin at that same time. It will not make you sleepy, but it will prepare you better for bedtime. And last but not least, high dose melatonin, 10 to 12 milligrams, is used for REM behavior disorder. So there are 3 distinct uses of melatonin. If you're not a person who's melatonin sensitive, the hypnotic effect probably will not be much. Now, the most important way to minimize insomnia in Parkinson's is to have a really stable wake-up time and targeting about 7 hours or so in bed, not more than 8 hours, the average person. If you spend excessive time in bed, you're not going to be able to sleep because the Parkinson's brain can't generate normally as much sleep as the average brain. The sleep is more unstable. So you're really asking an unstable system to work too hard if you get to bed at 10 and hope to sleep until 8 the next. The 10 hours usually can't. Now, clearly, if you have hypersomnia, you probably should try to get that treated. High dose melatonin, I have patients who use 20, 30. The highest I've seen is 80 milligrams. And you can buy from Amazon, I've seen 60 milligram tablets. Please don't do that. Not a good idea. You would never go to CVS and buy Tylenol and take 10 tablets of Tylenol at the same time, right? I hope you will not. I mean, no one would think that's a good idea. Or take a whole strip of Benadryl and take all of them together. Please don't take Benadryl. Don't ever, ever take Benadryl over the counter. That's bad for Parkinson's because it affects your memory, and it's very long acting also.
And then
supplements. So GABA, GABA is available as a supplement. It can improve sleep a little bit. Methionine supplements. Again, if anything helps, two things. Not that more is better. So don't just keep dosing, but always do it with the full inclusion in the discussion and tracking of your neurologist.
And then what causes sleepwalking in Parkinson's?
So sleepwalking itself is not very common in Parkinson's, but REM behavior disorder is. But in general, sleepwalking, the mechanism is that there are normally transients during sleep. That is, transitions from lighter to deeper and deeper to lighter. Now, in the deeper to lighter transition, the ongoing sleep, the deeper sleep, has to turn itself down into a light stage, and then we wake up transiently, and then we go into the next part of sleep. People who are sleepwalking tend to have deeper than average sleep, and they abruptly transition. Instead of a gentle swing into lighter sleep and then go to the next sleep cycle, they abruptly transition into full wakefulness, at least substantial wakefulness. So different parts of the brain are simultaneously asleep and awake in sleepwalking. What we do when we sleepwalk are things which we know how to do, or these are innate. Innate means these are neural programs we are born with. We are born with walking programs. We are born with movement programs, grasping, eating. All of us can do that without even learning how to do it. So you will not sleepwalk and drive a car if you don't know how to drive, as an example. You could get into a car and grab something, but you would not drive it well. Parkinson's, you can have sleepwalking occasionally, but it's not a big problem. With medications, high dose melatonin, sleepwalking can be a problem because you're making sleep deeper, and the Parkinson's sleep is more unstable. So you combine instability with depth, you have a bit of a substrate for sleepwalking. Of all my Parkinson's patients, I have maybe 3 or 4 sleepwalkers only. And they were sleepwalkers when they were much younger, then they were fine. And now with Parkinson's, their sleep is more perturbed and their sleepwalking tendencies are coming out. But REM behavior disorder, where you act out your dreams aggressively often, that is common in Parkinson's. And for that, we've got to have protective mechanisms around the bed, in the room, melatonin, benzodiazepines like clonazepam, and they can be useful.
And then just one more question on lorazepam, if you could address the use of lorazepam.
It's a benzodiazepine. All benzodiazepines come with a certain baggage. They come with a certain set of benefits. So benzodiazepines improve sleep continuity. It reduces sleep depth, but it increases sleep stability. It reduces arousals from sleep. It reduces movements during sleep. It reduces spasticity. It can relieve tight muscle tone. Those are the good parts of benzodiazepines, and that means lorazepam, clonazepam, temazepam, oxazepam, all the PAMs. The dark side is that all almost all of them are not short acting, they're long acting. So you take a dose at bedtime, it's in you when you wake up in the morning. It causes unsteadiness. So the system which it targets, the GABA, GABA neural system, is very involved in regulating a lot of things, including balance. So your balance is impaired when you take a benzodiazepine, and if you're trying to walk, as an example. So your risk of fall goes up. They can be hangover. Benzodiazepines strongly inhibit short-term memory, and that's very good. If you get a benzodiazepine before surgery, it causes a amnesia. You know, it's part of the amnesia cocktail, amnesia pain cocktail you get for surgery. But a vulnerable brain is more at risk for having these kinds of problems. So we try to avoid using a benzodiazepine in Parkinson's and Alzheimer's and all that. Now, there is a little bit of epidemiological data, a few studies showing an increased risk of dementia and death in those who use benzodiazepines. The data is complicated because when you look carefully at the data, the actual time of use of these drugs is usually when in the last few months or years of a person's life. So it's quite possible it was being used to target something which is disturbing sleep rather than something else, which may, of course, be the reason why they have death or dementia. So it's called confounding by indication. So we don't know whether it really causes dementia or not, but it's definitely not good for a neurodegenerating brain to be exposed to high-dose benzodiazepines. Just not a good idea.
And then what causes a person with PD to be unable to find a position that's comfortable for long enough to fall asleep, and what can be done about it?
Well, if you're stiff from any reason, that's unfortunately true. It's true that if you have, severe arthritis, spinal arthritis, it's not unique to Parkinson's. I mean, trial and error. That's all I can say. There's no magic there.
And then how do you balance the need for a dark room for sleep with also considering safety for things like getting up to use the bathroom in the night?
Well, you have a bedside lamp. You turn it on before you make sure the light is low, but you turn it on before you do anything. I'm not saying you need to, go to the bathroom in the dark. Of course not.
And then what, if anything, can a person with RBD but no signs of PD do to delay the onset or lessen the likely of PD?
What I recommend to my patients is to stay as physically fit as reasonably possible. There will be trials on prevention once drugs are developed which can target Parkinsonian pathology. None of them exist right now, but they will, I'm sure. I would strongly encourage folks to enroll in that if they, when that time comes. But staying really physically fit, that's perhaps the best I can suggest. That's what I suggest to my patients.
And then
physically fit, and of course, eat well, blood pressure, take care of all the usual brain health things.
Great. Yeah, we have a couple more minutes. Let's see. What symptoms would someone notice if they had parasympathetic heart rate variation?
Oh, you won't notice anything specifically. It's something which we measure. You would not know Now, patients with Parkinson's, of course, have autonomic dysfunction, so their blood pressure can drop when they stand up and so on. That's a common, autonomic abnormality is quite common in Parkinson's disease. But what you would know is more feeling dizzy when you stand up, or your heart rate going either too fast or too slow when you stand up. But the sympathetic parasympathetic balance is something which we had to measure. It's not something you can feel yourself.
And then are natural remedies like warm milk with honey before bedtime effective in sleep disorders with Parkinson's?
No. Easy answer.
And then someone asked, at what stage might you decide to see a professional about problems sleeping through the night?
If you are sleepy in the daytime, if you are bothered by your quality of sleep at night, and you've done reasonable things like, having a regular wake-up time and, relaxing before bedtime, not drinking coffee late at night, and those kinds of things, it would be reasonable to, see a professional. And the decision at that time may be, just we'll do nothing for now, and that's fine. But a point may come where one could consider careful use of a sedative or do a sleep study, look for sleep apnea, treat restless legs or limb movements, and so on. So initially, less is probably more, but as the disease progresses, like if you feel you're suffering from your sleep, you should certainly seek care. That's a simple way to think about it.
And then what can those of us with PD do to try to prevent that chaotic breakdown of normal sleep cycles and patterns?
Strong light-dark cycle, regular wake-up time, the first hour after awakening, maximum light. You can buy a light box from Amazon, like Verilux Happy Light with adjustable brightness, and use it. Keep the light box 2 feet in front of you. Don't look at it. Just get a blast of light every morning for about half an hour. And then, of course, don't target more than 8 hours in bed.
And then maybe one last question. This one's kind of a big one. Given the complexity of mapping the brain, what hopes do we have to find a cure for Parkinson's?
We have to understand what causes Lewy bodies and how it spreads. It may very well be that if all of us could live long enough into 200, as an example, maybe all of us will have Parkinson's. It's clearly a very strong age-related thing. Parkinson's is fundamentally a protein misfolding, more or less, a protein misfolding disease. And targeting the protein itself from misbehaving, once that is available and once that is done, I think the rest will fall into place. We don't have to worry about how widespread it becomes. Now, those who already have Parkinson's, reversing it is going to be difficult, but preventing it from going further is probably going to be possible. So it has to be something which fundamentally hits a fundamental weakness of the Lewy body.
Great. And
then very targeted.
Just one more, is sleep talking related to PD causes?
It can be part of REM behavior disorder. So if you talk a little bit, a word here, a word there, not a problem. If you're yelling and screaming in your sleep, that's probably an early stage of REM behavior disorder.
Great. Well, I think that's the time we have this morning. So thank you very much to Dr. Thomas for joining us, and thank you to everyone who attended.